Hi everyone, I hope you're well today. In the interests of the bandwidth as such, we'll ask most of you to keep your cameras off. However, when you've got questions, please do put your cameras on, because we do want to make sure that this is as interactive as it possibly can be. I'm Sue Wallace. I'm the Chief Finance Officer for the Trust, if you don't know me. Also, I led the implementation in terms of the EPR as well. I've got a number of people from the EPR team and some of the areas that you'll be familiar with as well within your own departments to support this Ask EPR session today. And the intent is really that we go through as many questions as we can. We won't be able to answer them all. It's just not possible. And there is a huge range of questions, as I'm sure you would expect, from very specific questions to more general ones. And we'll make sure that you are signposted to the answers to all of those after this session. And that may be through some of the training that we intend to provide as well over the next few weeks, as well as the direct answers to those questions. So thank you all for joining me, because we really do want to hear the feedback and understand what's been happening. So I'll give you a little bit of an update, I suppose, to start with, and then go into some of those questions that you've sent through. So just by way of update, so in terms of the implementation of EPR, so you'll already know that it was the biggest implementation in the UK, and actually that does mean that we have adopted most of the modules that Oracle Health offer as such in terms of the system. And of course that does mean, though, that it has been complex in terms of adopting that system and changing to the new ways that we work. But I think actually, if you compare us to where we were a few weeks ago, then we have moved significantly forward. Someone got a problem? Sorry, wasn't quite sure whether I heard a voice there in the background. But in terms of where we are, so we have resolved now 16,500 tickets, which is incredible if you think about it. And we've had 2 buildathons. So if you have been able to access TrustNav and look at the buildathon pages, you'll have seen that there's been around 40 fixes per buildathon that we've been able to do, and the EPR team together with Oracle have been able to do on the system, which has addressed some of the early issues and some of the problems that have arisen. Which is brilliant. And also we've been running what is stabilisation groups to address some of the challenges again that have occurred. So we've had a number of stabilisation groups that have been in operation, overseen by individual chief officers together with EPR team and support to work through a range of issues. We've also started our digital risk group, which has been overseeing all of the datexes and clinical hazards that have been raised, to make sure that obviously we are targeting anything that has risk associated with it, both in terms of training and adoption, but also in terms of technical fixes as well. And also we've optimised a number of workflow issues. So there are a number of workflows that have been changed as a consequence to us moving through the system. There've also been a number of really positive outcomes of people using the system as well. So certainly in terms of the prescribing side, also in terms of some of the information that you can see and some of the photo facilities, etc. That has worked incredibly well in terms of the information that's available. So there have really been some successes around that, but we do also know that there are still a number of challenges. So hopefully this is the first session of several that we will run, and I know there are other various sessions that run as well, which will still carry on. But this is the first of an ongoing series, if you like, to try to get to the bottom of some of the queries that are still outstanding. So as I say, please do feel free to put your camera on when I ask for questions. So I'm going to start though with some of the ones that have been pre-submitted, if that's okay. And I'm going to go straight into the first question, which is really a bit of a theme question in the sense of it's about the MPTLs. So first question is really around redirection of patients on the MPTL. So is it possible to redirect patients on the MPTL, as not all referrals accepted and redirected to another department? And then second to that one is one around the system does not allow you to add comments when you accept referrals on MPTL. Can this be amended? So I'm going to hand over to Linda for the answer to this one. Linda, if you could introduce yourself as well ahead of giving a bit of a reply about that.
Great, thank you. So to those people who haven't met me, my name's Linda Wood. I'm the interim head of digital clinical systems. So I'm part of the clinical systems team that's in the back office role, helping supporting the EPR programme. And the MPTL is something that I've been spending a lot of time looking at over the past 14 weeks. And I know there's a lot of people that are using it in the organisation. Sue was referring earlier to some training sessions that we're going to be running. So we're going to be rolling out some sessions based on a theme of the week. So each week between now and Christmas and probably in the new year, we're going to be picking a theme and we're going to deliver some bespoke sessions around those themes. And the MPTL is one of the ones that we've got on that list because it does come up in many areas. So please do come along to those sessions. We're hoping they'll be well supported. So they'll be for our digital champions and for people out in the organisation to come and just learn a little bit more about some of the functionality. Specifically to those two questions, unfortunately, it's not possible to redirect referrals that land on the MPTL. You have two options. So if you receive a referral that's not appropriate for your service, you can reject the referral. And in doing so, that sends a message back to the lead clinician for the patient to explain why you've rejected it. And there'll be a number of reasons why referrals do get rejected. And secondly, you could place the referral to the correct team. So if, for instance, you were working within one of the therapy teams and you received referral and it should have gone to one of the other therapy teams, then you can place a referral to make sure that they get that information. And that ties in quite nicely with the comments question. So the question alludes to the fact that when you reject a referral, you can type a comment onto the referral to explain why it's been rejected. And at the moment, that functionality isn't there for if we accept referrals. But what's happening in the background is that the rejected message goes to the lead clinician. So it's explaining, I'm not accepting this referral because maybe they're still awaiting a diagnostic test, or we've already got a referral for that patient, we're already seeing them. If we were to open up the functionality that if we accepted a referral, we added a comment, then that similarly would go to the lead clinicians. So we would need to get agreement from the clinicians that they wanted to be receiving a message in their message centre when a referral was accepted. So technically we can do it, but we just need to look at the workflows around that. And I think when we get to optimization, so in a little while when we're going to be able to make some more changes to the system and we start to look at these workflows, that's something that we can certainly look at almost on a bespoke referral by referral process to see whether that's something that we want to encourage. So hopefully that answers, but there will be more information definitely about the MPTL when we run these theme sessions, and the dates will be coming out soon to advise people when they're going to be.
Thanks, Linda. Yeah, and I think those theme sessions, it's really important for awareness for everyone. So they will be coming out via comms and TrustNav. So just to make sure that you're all cited on those, as they will hopefully answer a number of questions directly. So I'm going to go on then. So the next one is around a question that's been asked around unable to amend priority of referrals. And I think Debbie, you're going to answer that one. So if you wouldn't mind introducing yourself as well. Ooh, is Debbie there? No, she might have dropped off. So.
I'm here. Sorry.
Oh, you are there. Sorry. So,
I was on mute.
This is a question. It's okay, no problem. We are unable to amend priority referral. Can this be changed as this is all more work, especially for 2-week wait referrals. We're currently having to delete the referral and add another just so the priority is correct.
Okay. Yes, thank you. An afternoon, everybody. I'm Debbie Finch, and I'm Deputy Manager within the Clinical Systems team, and I'm guessing most admin staff will know me. Okay, so in terms of amending priority, you are able to amend a priority on a referral before you accept that referral. Okay, this is all outlined in the QRGs that are available on eCoach. And again, to note that we do have the admin forum scheduled for this Thursday at 1:30. That's chaired by Gabby Harris. And again, we can run through bespoke questions around referral management.
Brilliant, thanks, Deb. So hopefully that answers that specific question, but really important to use that admin forum as well on Thursday to make sure any further questions can be addressed around that particular area. Next question then, moving on. So this is a cross encounter, and we all love it, encounters, don't we? But this is the cross encounter question. So if I could ask Penny to answer this, please. So this is about I've dropped off my own list there. So this is about puts patients at risk of double prescription and too much investigation. So as radiology department keeps calling us that patient already did some investigation, especially when it's not being reported. So can we have an answer around the cross encounters, please?
Thank you, Sue. Hi, everybody. For those who don't know me, I'm Dr. Penny Hayoglu. I'm a consultant oncologist, CCIO and Deputy CMO in the Trust. Cross encounters, especially from AD to our assessment units, has been identified as one of the clinical hazards before go live. And what we did is we put a team together led by Mark Pell, our clinical safety officer, and emergency medicine consultants who put SOP together, which was tried and acceptable by the group and trained as part of the EPR training. Now, we recognize that the SOP has been a temporary solution to transferring from encounter to encounter in emergency units, and we now understand that this has been quite complex for junior medical staff to do, and therefore we are working with an external provider to try and find a solution to make it a lot easier, which is going to reduce the time that's needed to do the work from encounter to encounter. So it's something that we are actively working on.
Thanks, Penny. So I'll just move on then. So we're now looking at our next question, which is around being able to view or basically investigations. So cannot see when an investigation or order is booked. So question is, why can we not see orders that are requested for patients? It's not always possible to see if an order has been raised. So I think I've got Ferris as being able to answer this one.
Yeah, thanks, Sue. So I'm Faris Izzat. I'm a consultant obstetrician gynecologist and deputy CCIO here at CW. So there were two prongs to that question. The first one was about results, and results will any result for the patient that has been requested with an EPR will return to the patient's record, regardless of which encounter you're on. So I get asked a lot in terms of the result is not there. Do I need to go to a specific encounter? And the answer is no. It will be visible across any encounter. So any result of a test, and even those requests that have been done pre-EPR and CRS, those will be linked to the patient's record. So there should be no problem identifying any patient's result. Requests or orders, as the system calls them, is slightly different. A request is linked to a specific encounter. And if somebody, for example, has requested a test in ED on that specific encounter, and then the patient gets admitted to hospital, there is unfortunately the need to go to the ED encounter to look at the request and where that request is in the process. So any order that has been raised for a patient, if you go to it and then you look at the order details, you can see the status of that. So whether it is pending, where it is in the system, whether it's at the lab or in the radiology department. So you can still follow up a request for a patient, but they are at the moment encounter specific. And that is a common theme where people, unfortunately, if you request against the wrong encounter, you will find it difficult to find it. And that is unfortunately a limitation of the system that we can't change. But results of patients' tests will always be visible in the patient's record.
That's really helpful, thank you. I'll move on then to the next question, which is around ECGs and blood gases. So this is around ABG and VBG are not integrated, so are the ECG, apart from the clinical images. So can I have a bit of an update around this, please, in terms of Penny, please?
Yes, thanks, Sue. So VBGs and ABGs are integrated within EPR, which means you can view the results there. ECGs, not yet, but that's the next step in the optimization process that we are working actively on.
Thanks, Penny. Next question then is around prescribing issues. So this is around if certain drugs are restricted, e.g. for consultant only, then why does the EPR let other staff prescribe it? This is a safety issue and the problems are being blamed on the clinicians. I don't know who can give me an answer around that one.
Hi, I'll take that one. So, oh, Ferris, go ahead.
No, sorry. I just wasn't sure whether. Carry on, Karen, sorry.
I think it was from an advanced nurse practitioner, advanced care practitioner.
It was, absolutely.
So hi, I'm Karen Bond, Chief Nursing Information Officer for those that don't know me. In the past, when we were prescribing on paper, obviously as advanced care practitioner, advanced nurse practitioner, we have our scope and our drugs that we prescribe. It is the same on the system. So you have on the system the same role as our medical colleagues. So we are ClinPrac is the role that is given to us so that we can prescribe, but the same scope and professional accountability applies as previously when we prescribed on paper. So you prescribe the drugs that are within your scope. The system will not stop you prescribing those in the same way as the paper and pen wouldn't have.
Thanks, Karen. And that's really important that we remember actually around the system actually and what it means. There's certain bits that are system elements. There's also certain bits which goes back to what the previous professional roles were. So next question then is around WOW printers, and I know printing has been an area of concern again from an advanced clinical practitioner. So this is around the label printers on WOWs are very hit and miss. I had to go back onto specimen collection 3 times and select another printer because the first 2 would not print. On some WOWs there's a huge list of connected printers but does not include the one attached to the WOW. We never had any training on these printers. So I'm not sure who's best to place that one, but if I could have a hand up from the EPR side, that would be great.
I think this is more of a technical one, but I can answer it if there's nobody technical on the call. So yeah, I mean, there was an issue in the first couple of weeks of printers not showing for the specific request, and the way that the system works is that the patient's location is the vital part of where you can actually print out from. So, and I'll use an example. If I'm in theatres and I'm requesting a test for a patient who's in the recovery, then the printers for the recovery area will appear. And that's how the system has been designed. And likewise, if I'm requesting a test for a patient who is in a different location, those are the first printers will appear. There was a bit of work that the technical ICT team have implemented so that the actual printer that's attached to that specific PC or WOW will appear on that list, in addition to those where the patient is located. And I believe a lot have been modified so that that printer appears on the list. But if there are printers that are not appearing next to a PC or a WOW, that can be fixed by the ICT team via the standard route. So yes, there's a bit of design and there's also a bit of there's a fix for that as well. but if there's anybody technical who knows how to do that, I'd be grateful. But yeah, it works in that particular way.
I've got a hand up from Paul.
Everyone, sorry, I've got no camera at the moment. It's playing up on me, so apologies for that. It basically, if we do get the calls coming in, so if requests does come into us, we can rectify that. It does sound like there's something out of location there, or you know, a printer for whatever reason has been moved. So yeah, if we could just give us the opportunity to fix it, it'd be great. Just so raise a request, we'll get it sorted for you. So apologies, I didn't catch the person that you know, identify the call, but if you could drop me a message, and then we'll see if we can sort something out for you.
Fabulous. And Paul, we can forward that detail as well. So
yeah, that's smashing.
That's really helpful. Brilliant. Thank you. So I'm going to hand over now, if that's okay, to sort of the live questions as such. So we've got some more that have been submitted, but I think just so that we get everybody on the call and we pick up everybody on the call. So does anybody want to ask a direct question? And if you do wish to, then it'd be great for you to turn your camera on and to see you as well. I have got Rachel.
Hi, good afternoon, everyone. One of the issues that we'd like to raise, and we have raised an ICT ticket for, is that Proforma that was created and built into EPR for us to use when we assess patients. There's been lots of glitches over the last few weeks where as you type into the Proforma, what's already there and formatted disappears, and you can't recover it. And it's happened 2 or 3 times, and you then can't literally follow what we would normally follow within our clinical service. So we then have to then create a blank note and try and remember everything that's on that Proforma to populate for that patient. We've tried coming out of the patient, going back in. So a ticket has been raised for it, but it had been working perfectly fine without any issues. So why would something like that happen, that a built Proforma then starts to not work as it should?
That sounds like a bit of a technical question, so I don't know if we've got anybody from the technical side to answer that, or maybe it's a Linda question. She's very quickly turned her camera on.
Hi, Rachel.
Hi, Linda.
It's kind of a Linda question, only because I built the templates in the first place. So I haven't actually seen your ticket, Rachel, so I'm more than happy to have a look at that. As to why something that was working before suddenly stops working, there can be a number of reasons for that. And once we've got the detail in the ticket, I'm more than happy to have a look at that. Sometimes it might be that we've changed one thing and it has a negative effect on something else. So it might be that one of the templates in the background has been altered for something else. So I'm more than happy to have a look at it, and I can bring a better answer to this meeting once we've had a chance to investigate it. So if you want to just Teams me over the incident, we will have it. It's just not on my queue, and I can pick it up from where it is and work with my colleague, and then we can get back to both yourself and the wider forum to see what the issue was there, Rachel. I'm more than happy to pick that up.
That's lovely. Thank you.
No worries. Thanks, Rachel.
Thank you. And we've got Lisa next.
Hi, I've got a couple of questions. My first one is relating to all of the pop-ups. So the services that I manage are generally outpatient services, but we'll often receive referrals while patients are inpatients. So we want to go into the patient record to learn a bit more about, to be able to triage and decide if they're appropriate. And there are so many pop-ups, some of which that you have to do twice, when you go in and when you go out of the record, which obviously is very time consuming. You have to individually document why you're not going to do whatever assessment or task it relates to. And then the flip side of that is when you're trying to review a patient's record, their documentation tab is flooded with incomplete notifications of incomplete resuscitation assessment or pharmacy reviews or delirium screening. And it just makes accessing patients' records so much more complicated and time consuming. And I understand the need for this visual alert that a really important task hasn't been done, but I do wonder if there's any way of minimizing that arriving to people that it's not appropriate for. And equally, why do we need the same pop-up twice in one episode of looking at the notes, I guess.
So, and I think we've had that as a pre-submitted question as well. So I think it's useful to understand how we could take that forward. So, is any thoughts from the EPR side?
Yeah, so I'll come in and then I'll let Ferris come in. So I absolutely share your frustration in terms of those pop-ups, because obviously we get the pop-ups when we're doing investigations in patients' record as well. I mean, the honest answer is that a lot of the pop-ups are coming because things haven't been completed on the ward by clinical staff who could have completed those things. So like VTE assessments and resuscitation status and those kind of things. The pop-ups come after a period of time because they haven't been completed in a timely manner. So part of the response is about people who do have kind of the care of those patients finding the capacity to complete those things in a timely manner, much the same way as you had alerts within CRRS and things that had to be completed. I think the second part of that is to do with them filling up the documentation space. And you're right, things like the anti-infective review form. We've had conversations just this morning, in fact, about removing that from the documentation section. So there are forms that are generated by people dismissing alerts, which are filling up documentation, and we can turn those off so that you'll still be able to see them in the system, but they won't fill up the documentation page, and then you'll be able to better see the clinical notes. So that conversation, in fact, happened just this morning, and we are looking to progress that.
Great. Is there also a way where the alerts don't appear twice in the same episode of looking in the notes? So as you enter and exit the patient record, you have to fill the same alert in. Not for all of them, but I think there's a couple specifically that you do have to do that for. Can that be altered?
Yeah, so I personally wasn't aware that we had any alerts that were both open and closed chart. I thought
think
they were all one or the other.
I think delirium is open and closed, and there is a second one, and I can't remember which one it is.
More than happy to have a look at those. Yeah, because you're right, some of them you can't fill in when you're opening the chart because you don't have the information about the patient to be filling in the information. So it makes sense for those to be closed chart alerts, but it certainly doesn't make sense for them to be both. So I'll have a look at the delirium one. That's definitely something that we can look at to make that a bit smoother. If you find the other one, drop it over, Lisa, and I'll have a look.
Thank you. Do you have time for a second question from me?
Go on while you're on.
So my other question relates to encounters, and I think it's really important to mention as a learning that encounters didn't feature in any education that I received prior to go live. And in fact, encounters are really, really important. They're really, really important that you understand them. So I think a learning for everyone that delivered the training on that is perhaps we should have had a bit more information before go live. And then my second point around that is we still haven't had any learning. So for the teams that I work within, we're a multidisciplinary team, and what we still don't know is should we have a separate encounter for the interactions with the consultants and a separate encounter for the interactions with the nurse and a separate encounter for the interactions with the physio, or should it be one encounter for the service as a whole? Equally, I work within respiratory, and so we might see a patient that sits under a different consultant's encounter. So one of the respiratory consultants might ask the respiratory nurses to do an appointment. Do we book that appointment under the original consultant's encounter, or do we create a new encounter for our service alone? Because it affects whether or not how you can discharge, because if we're seeing them on a one-off basis, but we've booked the appointment against someone else's encounter and we discharge, you in effect cancel all future appointments, and all unfulfilled investigation requests also get cancelled alongside that. And I think there's a lack of education and knowledge around that and how we should be processing them.
Okay, so that's a big encounters issue. So I'm assuming, given that is such a big issue, that is going to be one of our weekly themes. So I think the important thing about that, because there's quite a lot, to be fair, to unpacking what you've just said, Lisa, and I'm sure it's pertinent to many people. So I think that the big thing here is to look out for those dates for the specific training that we're going to do for a whole week around encounters being one of those themes on one of those weeks. And pick up all those issues. Is that okay, Lisa?
That's fine. Equally, will that education also go to the administrative teams, because they're the ones that book appointments? Again, so I know that one of my administrators will see that there's an open encounter within respiratory as a whole division and will book our appointments against that. And is that the right or the wrong thing to do, or should it be specific for the service that sits under respiratory as a umbrella sort of thing?
So I'll give a little overview, and hopefully I've been listening to the team well enough to give this, but I'm sure they'll correct me. Is that actually the intent is that we focus on a theme for the whole of the week with all aspects of that particular theme. So yes, absolutely in terms of admin, but also in terms of every aspect as such, so that we almost get a joint approach from everybody. Is that fair, Linda?
Yes, absolutely. And just a reminder of the admin forum that Deb mentioned earlier in the meeting as well, that if the admin colleagues have specific questions, they can take them to that forum as well. But yeah, the theme of the week sessions will be open to anybody, because there are lots of people completing things within the system that we can't predict that that's what they would have done. So it's important that everybody feels that they can attend those sessions. So yeah, admin or clinical, the more the merrier.
Thank you. I've got Simon's hand up there. Is that a new question or a follow-on from what has just been said?
No, thank you. It's a new question actually. A couple of questions. I'll try and be really quick. Firstly, it's something that came up on one of our waste walks with the general internal medicine team for medical outliers. We're trying to find ways of making ward rounds more efficient, having quicker access to information, especially for those that are on the move going to different wards at different times. The teams really struggle getting access to the computers on the ward and the WOWs due to them not being the primary specialty. They may be seeing 2 or 3 patients per ward. So there's been a request. We initially had a request for, say, 2 iPads for the consultants to use as they go around the wards to check things in real time. But we've been informed that iPads don't have access to EPR. And so we just wanted to find out, is there a portable option for EPR, especially for, say, consultants and maybe even a senior registrar who's going around the wards, so they can check results in real time, do referrals in real time rather than waiting for a computer at every stage, because that is slowing us down, slowing down the clinicians actually. So we're trying to find an option for a portable, portable EPR kind of interface really. I just wonder if there's any options.
That's James put his hand up pretty quickly there. Oh, James, you're on mute, I think. Well, we can't hear you anyway. Oh, I can't hear you, James. Can anybody else? No.
No.
Can't hear you, James. Does anybody know the answer to that? Or if not, we'll get James to type it into the chat. James is off and on again.
I don't know whether Ferris wants to go first. There's a couple of options that we could talk about with Power Chart Touch. Ferris?
Yeah, I mean, that's what I was going to say, is that there is a mobile application that is a fairly stripped down version of what the actual desktop version can do, and there are plans to deploy that in the near future on devices, and that is being formalized at the moment. I suspect it will do a lot of what the team that you described would want to do in terms of monitoring charts and looking at documentation. So that can hopefully make a big difference, and that was always on the plan to roll out soon.
That's great, thank you.
And just to support that, another piece that we're doing is looking at everywhere that we've deployed WOWs and equipment to, because we knew it wouldn't be 100% right when we went live. It would be as close as we could get it. So we will be looking at, we can see usage, etc., and we'll be moving things around to help facilitate where there's high numbers on ward rounds, etc. So hopefully the two things together will help improve things.
Okay, so how about that and WOWs review?
That's lovely, thank you. And that's my second question, something related to our kind of active waiting list, actually, the PTL. For example, general internal medicine, again, one of my specialties. We're struggling with changing, say, the primary specialty that the patient's been referred under. So they'll, even though the patients either correctly or incorrectly come under GIM, if they're quickly then being seen by or taken on by respiratory and the pathways further down, and even as a ongoing and never actually needed to be seen by GIM, everything's kind of static on the waiting list. So every report will come through, here's our longest waiters, GIM, for the RTT, and we know it's not the case. We know that actually other teams are actually seeing them actively, unless they're obviously for the NSS cancer clinics. And so we're just a bit we get a bit stuck. The RTT team very kindly were trying to help us a few weeks ago, the access team as well, and we just didn't really get anywhere. And we just wanted to find out, is there a way that we can, as administrators in the background, change a primary specialty, so for where a patient's been referred, not just power chart, not just revenue cycle, but actually on the reports, it's essentially changing the primary specialty to be correct. So we're stuck on this one at the moment.
Would anybody know the answer to that? I think we've partly picked it up in the early question, but it would be able to answer that. I don't know if Linda, you would have an answer to that one. Maybe not, to be fair. No, just a shot. Anyone know
Found one.
Okay, fair enough.
Deb might.
Deb, sorry. Okay.
No, I don't have a specific answer, but I'm going to certainly take that away, Simon, and we'll liaise with patient access team and yourself, because I think Juliet may have raised a similar issue around the waiting list in the PTLs as well. Yeah. So we'll take that away and work on that.
That's very kind. Thank you.
Thanks, Simon. Moving on then to Lisa.
Hello. I did send this through, so you may already have looked at it. So I'm a heart failure nurse, mainly see patients in the outpatient setting. Previously on CRS, we could send a direct note to GPs for medication changes, that kind of thing. So if we'd seen a patient in clinic, we were concerned about them, needed them to go and see their GP that afternoon, we could send a note ahead of time that the GPs can see within 1 to 2 hours. We still have an access on the new system. There still is something called GP notes or that kind of thing, but apparently GP surgeries don't receive them. Do we know when this will become active?
You want to answer that one, Sue?
Yeah, if you've got your screen on.
Yeah, because this has been active actually from day one, Lisa. The note type is called GP. It's called ad hoc.
Yeah, we've filled
GP
those
letter.
in, but the GPs, I've even asked them only last week whether they can see them, and they said no. So it's just a bit of guidance,
Okay.
really. If they are active, where do they go to find them so we can let the GP surgeries know?
I mean, if we have some specific examples, we can trace those in the interface team, because when we created that note type and we tested it in the interface, it was going certainly to GPs, and I do know that GPs are receiving them. So as long as that specific note type, and that's the only note type that replicates the CRS note that used to go to GPs. So if the letter is actually created in that note type, which is ad hoc GP letter, it should, and as far as we know, go to the GP. Linda, have you heard of any tickets that's not going?
No. We had the same issue with the heart failure team in the community as well, over in Coventry, that theirs weren't going to the GPs either. So it might be something that's been resolved. But from my perspective, we knew somebody that worked at the GP surgery last week, and I sent the direct note in that way, and they didn't receive it. The only thing they could see was I had to send an ad hoc letter separately, and then they could see that. If you want to send over the details, I'll have to investigate. That would be really, really good, because obviously it can cause a delay in treatment for our patients. It's quite important. Yeah. And there's a number of people putting in the chat that GPs aren't receiving them. To be fair, we haven't had a single ticket raised about that. So it's really important that if people do find issues, it's great to bring the questions here, but if there's an issue that you think is potentially going to cause clinical harm, then please do raise a ticket with the details in it, because then we can investigate it and hopefully bring the answers back here so that we can try and explain some of the issues. Yeah, I think it was raised very, very early on, and we were told that it was being looked at, and then there was another meeting that one of my colleagues went to, and it was going to be looked at that. So yeah, as Jackie's saying, tickets have been raised, because I know it's something that we've felt quite concerned about, really. Okay. Also, I apologise, they haven't crossed my path. That's fine. If you've got tickets raised, if you want to send me over or put the ticket numbers into the chat, just with my initials in front of it, LW, then I can make sure that I pick those up. It's just, for myself, I'm a nurse prescriber, but my colleagues aren't. So they're asking the GPs to increase medications, and they're reliant on them receiving those notes. So it's just got quite important. I missed where you said we're going to see the ECGs as well. Where did you say exactly we'll find those? Because I'm having patients at Rugby having ECGs taken, but they're not uploaded onto the system.
James?
Still on silent.
No, can't hear you, I'm afraid.
I can answer that one. I mean, so the ECGs, that is a future development. That is not something that we have, and that's probably going to be several months until we get that. So at the moment, there's no electronic version. I know ED are taking pictures of them and putting them in the notes as a clinical image, but at the moment, there is no electronic version of the ECG appearing in the records.
Is there any way they could be scanned on and put onto EDM or something like that? Would that be
Yes.
an option?
They are.
Yes, that can be done, and
Because-
ED are doing that at the moment. They're using the functionality within the mobile devices to take pictures of the ECGs, and camera capture is an application that's on all mobile devices in the trust that can do that functionality, where you can take a picture of the ECG and it'll appear directly in the patient's record.
Maybe that's something that could happen at rugby then, because I'm having to have them sent to me in the post, which isn't really ideal. So obviously I'm waiting to review these ECGs on some patients that I'm sending to have them done from home. But yeah, thank you anyway.
And camera capture is one of those things actually that's been hailed as a bit of a success in the sense of being able to do different things. So we just need to use that functionality. Any more questions with hands up at this moment in time?
See, there's quite a few questions in the chat, if you can see.
Yeah, there's quite a few to go through. Is there a hand as well, or is it? Oh, I've just put my own hand up. That's not good. Is there? No, I managed to do that. No hands up at this moment in time, are there? So, what about encounters? I think we've raised that already. Is there a way to stop letters and texts from being automatically generated from home visits? The letters and text pools and the details from the encounter and confuse patients. Is that something we can answer? Deb, you've switched on your screen there.
Yeah, I did type a response in there, but essentially the text reminder messages is managed by Performance and Informatics. So if you want appointment types included or excluded, you need to contact Performance and Informatics. In regards to correspondence, if letters are incorrect or you want prep, amending, etc., then please raise a ticket with those details and we can review those.
Just to remind people as well, the more specific you are about the tickets and any detail that could be given, it allows the teams to investigate them. Lisa?
Thanks. Just in response, Deb, so am I able to request an absence of location information in one specific appointment type, or will it be for my entire encounter? Because I need it to be able to be sometimes, but not all times. And that's the same with the amending of the letters. I've already sent a ticket off for a letter amendment, but that's to change the template. There might be one-off occasions where you might want to write something a bit more specific. We had our Oliver McGowan training quite recently, and actually if you've got a patient with with neurodiversity, you might want to be a bit more descriptive in your letter about where exactly to go and what you might see. And there used to be that functionality in IPM.
The system isn't as flexible in terms of letting you adapt the letters yourself. But if we need a standard paragraph following Oliver McGowan training, then we can certainly look to create that as a prep or an additional paragraph that you could then pull into existing templates. But we're certainly happy to look at that and see how we can improve it, Lisa.
Okay, so fine. So it's letters, the template letters presumably associated with the appointment type or the resource
Correct.
type or the
appointment type.
Okay, and then the informatics response about if I want the location removed, is that for appointment type or is it all or nothing?
If it's a home visit, if that appointment type is built against a home visit, then I'm assuming P&I would be sending that information. But again, you need to speak to P&I in terms of the data fields that they're including in their text messaging service. But if you're saying that that clinic is usually held in clinic 3, but on this one occasion we want to visit the patient at home, then yeah, we need to look at that. I'm not sure how we would exclude one text message if the appointment type is essentially clinic 3.
Yeah, because for our patients, they'll come into clinic for consultant or nurse, but the physios will do a home visit, and that leads to immense confusion. So
do they have their own appointment type?
I don't know what encounter. We all sit under the same encounter currently. We don't know how we're supposed to be managing it, and therefore what our options are and how we fix any of it.
I can pick it up with you separately, Lisa, and we can look at your appointment types and locations.
Thank you.
So I'll just carry on then. So just in terms of any hands that are up, so I haven't got any hands. I've got a few questions that have been typed in. Patient appointments can be seen in Power Chart, but it does not show radiology appointments, such as X-ray. Where can we see radiology appointments?
Radiology appointments will appear in exactly the same place as all requests. If you go into the order section, you will see in the order, once an appointment is being generated from Soliton, it will appear in that order, and it'll tell you when the appointment is created. If one is actually given to the patient, often they get vetted and processed quite some time after, and then the appointment will appear in the order.
Okay, thank you. There's a question here around, let me just go back. Will there be a search facility added to the work lists? Neurology was previously in partial booking, so now we have over 4,000 patients over 6 work lists, and searching for a patient is impossible when Mr. Smith is on the phone asking when is his appointment due. Is that Deb?
Yep. So there is no ability to apply a filter across the work list at this stage. It may be something we have moving forward, but right now that's a no. But I do believe if you were to look at patient perspective, you should be able to see sight of their individual requests against that patient. I'll find that in a QRG, and we'll talk about that on Thursday. Happy to talk about it. Yeah.
If we can go through that on Thursday, I think that would be very helpful. No more hands still, so I'll keep going. In terms of where we are, then I'll go back actually, if I'm okay, to the pre-submitted questions. So, question here about past appointments that have not merged over. So let's have a look at these specific. There are no past appointments that haven't merged. Do we have to
stop messing?
Sorry, so do we have to add a new referral in these situations? Is that Deb again?
Yes, it is. So all open referrals encounters were merged. If there is no open encounter, that will be because that referral was discharged in IPM previously. So if you wish then to make a further appointment for that patient, you will need to create a new encounter and book a new appointment. And I understand there are frustrations in that some patients were discharged previously and we had the ability to reopen that referral and book a further follow-up. But actually, if that patient had been discharged, that was the end of their care and a new referral should have been created. And the functionality now forces us to do that, create a new referral and a new appointment. So there has been some workarounds that have been used to bypass that and create a referral and book a follow-up. Well, book a new, book a follow-up, cancel the new, and now that has resulted in data quality issues and issues for clinicians in not being able to check out that follow-up appointment. So I would urge admin not to follow that workaround.
Yeah, I think that's one of the things about the workarounds is that it has created more issues than actually the particular workaround has solved. So I think if there are any concerns about the process, obviously we've got the QRGs, but also in terms of the forums as well, please make sure that we're following the right process. That's where it tends to go wrong in terms of the EPR. We've got Jane.
Simple question. When you're looking at documentation, you have previous and next. Can we actually have first, last, and the number of pages in between on PowerChart? Because I was skipping through, I don't know how many pages the other day looking for letters. And if you've got the numbers, you could take a note of what number your letter was on.
I don't know if that is a future development and we might have to take that away, or someone might know the answer to that. It sounds like something that we would need to look at. I don't know. Linda?
We'd need to go back to our Oracle colleagues and ask if that's technically possible, but we can certainly do that.
So that's what we had in the past, wasn't it? Where you could see the number of the number of pages, but to just keep skipping backwards and forwards. I don't know how many I skipped backwards and forwards to try and find the letter again. Quite time consuming. Okay, thank you.
So that's a future development potentially. So it's more of a technical issue. Stephen?
Yeah, at the moment, but EPR isn't BARS compatible. When will EPR be BARS compatible?
And who have I got to answer that one? So BARS compatible.
Can you hear me?
Ah, yes.
So we're working with Oracle as our supplier at the moment to make this happen. We don't currently have a timeline. I think I'm hoping by the end of this year, but we don't have any confirmation of that yet. So it's something we're working through with the supplier and looking at other options as well in the background.
Thanks, James.
Okay.
Thank you. So we've got Assad. It's Hash, actually. I should know who that is. Sorry.
That's okay. It's just from a coding point of view. So post EPR, the amount of information the coders now have to look at is quite a lot. So for example, the other day, one of the coders went to 2,500 notes on PowerChart just to extract 2 bits of information that we could code. Is there a way or an opportunity for us to amalgamate all the information that from a coding point of view that we need into one form onto PowerChart, or something that we can build to help get the coders coding a little bit quicker than they are at the moment?
That sounds like a sensible question. Is that something that, James, you can answer?
I don't think I can answer that question. I think we'd have to work through what you needed, because the information obviously available in the record, but we'd have to find out if it's a document type we could create or some other form to address that. I'm not sure if there's a simple answer. I think it's something we'd have to work through with your Hash and your team around what you need, what are the key things from that. Lots of the things are in the end pages for the relevant patients, but I think we'd have to work through and find out what's the key bits for coding. I'm not sure if Ferris or Linda want to say anything different.
So this comes down to similar sort of thing that we talked about in terms of alerts. I mean, ideally, we need to standardize what node types people use, and that therefore you can filter the node types based on what information you require. It's certainly something that we need to optimize and work on with all groups in order to standardize the node types that are used in order to find that information at a quick glance. But unfortunately, at this moment in time, I mean, just by looking at records in part of my job, I found a huge variety of different node types that are being used to capture the same type of information. And it's certainly going to take a lot of time for your team to find that. But it's a very good suggestion, and I think we can certainly look into how we can improve clinical documentation. It's certainly an optimization piece, and standardizing the way that people document is always the key in terms of finding that information. But in terms of creating a note or a specific document that captures that information, I think it's not a bad idea, but it's a bit of a bit of work that we need to figure out how we're going to do it.
Certainly one we should take. It sounds a very sensible idea. So it's definitely something we should take away and see whether that's a development piece. Jane? Oh, Jane, was that a previous hand? Potentially, yeah. Okay, so if we just look, so there's been a question here about cannot see appointments when cancelled or rescheduled. So this is about, we can't see the appointments that were cancelled or rescheduled, just the current existing one. The system should allow all appointments. This is confusing when ringing patients, when patients ring and looking things up. Deb?
Yep. So if you actually look at the patient perspective and display the appointment history, you will be able to see those appointments and that level of detail.
Okay. So another question around, is there a solution around booking follow-ups? So this is around, is anyone actually coming up with a solution around booking follow-ups when there is no referral to pick, as it seems we're just causing ourselves so many problems, not realising until later the consequences?
Yeah, so this is what I referred to a few minutes ago as well, where the functionality is that you have to book a new appointment against that encounter before a follow-up.
Okay, so if we get any final questions in terms of people's hands up here? No, so in which case then I'm actually just going to close this up now, if that's okay. So you've had, I hope you've all found it useful. The intent is that we keep these sessions going. I think the main thing I would just urge people is to really look out for those weekly theme training sessions, which will focus on all disciplines as such. So please engage in them, because the idea is that we solve a particular issue across the whole board as such. And then the other thing that has been mentioned, I think we've got quite a few admin type queries. I know we've not had time to go through every single one today, but make sure that if you can attend the admin forum, because that will be a way in which we can pick up en masse those admin type queries. And certainly when we're looking at those weekly themes, we will be thinking about those things that are being raised frequently to feed into those training sessions, to make sure that obviously we tailor those as much as possible. So I know we've got someone there that said I haven't received an invite to the admin forum. So just to make sure that you are invited if you think you fall into that category as well. So just to make sure that you do engage with that. As I said, all the fixes as well, both in terms of the build-a-thons and also the training, etc., will all be on TrustNav. So make sure you know where that is so you can access that. So I hope today's been useful. I'm going to close this down now. Thank you for your time, and thank you, of course, for your ongoing patience around moving forward with the system and engaging with us. It's really important that we work together to make this the best it possibly can be moving forward.
Thank you.
Thanks all.
Thanks, Sue.
Thank you.
Thank you.
Bye all. Bye.